I am Dr. Amin Khawaja, consultant anesthetist at National Institute of Cardiovascular Diseases, Karachi. I am going to talk on assessment of airway in COVID-19 patients. I have nothing to disclose and no conflict of interest with this presentation. The learning object in this presentation will be assessment of airway, signs of difficult airway, assessment of situation and assessment of hemodynamics. The coronavirus is a broad umbrella term. It is known for many decades, first described somewhere in 1960s. On 11 February 2020, WHO came with this pandemic coronavirus as SARS-CoV-2, that is severe acute respiratory syndrome coronavirus 2. Why it is important to assess airway? The respiratory events are more common in anesthetic related injuries following dental trauma. Predicting difficult airway allows to have extra equipment available, change your approach. So one can plan for awake intubation, but it should be avoided in COVID-19 patients because tracheal intubation is aerosol generating procedure. So as I said to you, tracheal intubation is aerosol generating procedure. Other includes mask ventilation, CPR before intubation, bronchoscopy, tracheal suctioning without closed time system, non-invasive ventilation, tracheostomy and extubation. Airway assessment should be done from 6 feet distance. It should be limited and based on individual clinical assessment. It includes history, physical examination and scoring system. History includes adverse events related to prior airway management, radiation or surgical history, presence of scar or the fixed flexion deformity of spine, history of burn injury, presence of swelling, tumor, mass, history of obstructive sleep apnea, problems with phonation. Again, the physical examination should be done from distance. It includes assessment of dentition, assessment of neck from front and side, and then the scoring system should be done. Mallampati classification is used usually for airway assessment. Oropharyngeal structures are visualized by mouth opening without phonation. Sensitivity of this test is 14 to 81% and specificity is 60 to 80%. To increase sensitivity and specificity of Mallampati classification, to predict difficult airway. In addition, some other scoring tests to assess airway should be done. Interincisor distance with the maximal mouth opening, the normal is about 5 centimeters. If it is less than 3 centimeters, results difficult laryngoscopy. If it is less than 2 centimeters, results difficult laryngeal mask airway insertion. This test is effected by temporomandibular joint and upper cervical spine mobility. Another test to assess airway is atlanto-occipital movement. In this, the extension of head on atlanto-occipital joint to see cervical spine mobility. So you can see in this diagram Grade 3 and 4 predicts difficult laryngoscopy. Mandibular protrusion test. If the patient able to protrude lower teeth beyond upper incisor, intubation usually is straightforward. If patient cannot get upper and the lower incisor into alignment, then intubation is considered difficult. Makoka score developed by French ICU, and it is also endorsed by UK difficult airway guidelines. It has got a maximum score of 12, the minimum is 0. If a score is more than 2, it predicts difficult airway. So you can see in this diagram there are 7 components of Makako score. That includes Malampati, grade 3 and 4. It scores 5. Obstructive sleep apnea scores 2. Limited cervical spine movement 1. Mouth opening less than 3 1. Coma score 1. Hypoxemia, if oxygen saturation less than 80, it scores 1. And the non-anesthetic intubator, it scores 1. If the score is more than 2, it predicts difficult airway. Once it is a difficult airway, then backup plan and intubation trolley contain all gadgets should be available. Intubation should be done by experienced practitioner. Either he or she should be senior resident, clinical fellow, or the senior anesthetist. The environment should be safe for staff and the patient. Institutional guidelines and the policies should be clear. Assessment should be timely without rush and delay. Avoid unreliable, unfamiliar, and repeated techniques. It is recommended in COVID-19 patients when intubation is required, it should be done in 15 to 30-degree head-up position. It suggests there will be no significant oxygen drop during and after intubation. The cardinal features when COVID-19 patient need intubation includes breathlessness or respiratory distress, tachypnea, increased respiratory rate more than 30 per minute, inability to speak, agitation, refuse to lie down, use of accessory muscles, sweating, and tachycardia. Signs of hypoxemia includes oxygen saturation less than 90, PaO2 and FiO2 ratio less than 150 when oxygen is given via face mask with at least 10 to 15 liters. So in conclusion, it is suspected or confirmed COVID-19 patients, airway assessment should be limited and mostly based on clinical judgment, using multiple tests to predict difficulty in airway management is better predictor than any single test. Environment should be safe for staff and patient. Assessment should be timely and avoid unreliable, unfamiliar, and repeated techniques. My presentation is based on these references and one can find in net easily. Thank you very much.